with us today to talk about a very important topic. I am thrilled to introduce Dr. Sam Pabich with UW Health, Abbey Harburn, Director of Analytics and Practice Transformation for the Wisconsin Collaborative for Healthcare Quality, Andrea Werner, Chief Population Health Officer for Bellin and Gunderson Health System, Jean Harris, Senior Director of Market Access for the Midwest region for Novo Nordisk, and Dr. Leslie Gordon with Watertown Family Practice. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News virtual series. These important discussions truly would not be possible without their support. So a huge thank you to AARP Wisconsin, Advocate Aurora Health, Anthem Blue Cross and Blue Shield of Wisconsin, Gunderson Health System, Hush Blackwell, and Quartz. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Gunderson Health System, today's featured sponsor. We are very grateful for all of their very generous and continued support. And here to say a few words is CEO Dr. Scott Rathgaber.
Thank you, Tim. On behalf of the more than 14,000 people at Bellin and Gunderson Health System who care for patients, families, and communities, I'd like to welcome you to today's Wisconsin Health News virtual event on obesity. As a local and regional leader for healthcare quality, Bellin and Gunderson is aligning practice, measures, and outcomes as core standards of care across our entire system. Our excellence in these standards was recently recognized by the Wisconsin Collaborative for Healthcare Quality. Gunderson is #1 for diabetes optimal control and cervical cancer screening, and is ranked in the top 5 for breast and colon cancer screening, depression screening, childhood immunizations, and controlling high blood pressure. Bellin is ranked #1 for depression screening, A1C control, and for diabetes annual GFR tests. Bellin also has top 5 rankings for breast cancer screening, well child visits in the first 15 months of life, and diabetes all or none optimal testing. Coordinated management of these and many other conditions are hallmarks of care inside our walls and with our many community partners. Our care teams work every day with patients and partners to improve outcomes and control costs by more effectively addressing conditions like obesity, which we can treat together if we work together. Patient-centered, community-minded care is Bellin and Gunderson's collective focus. I look forward to today's discussion and to our work together to help communities thrive. Andrea Werner, Bellin and Gunderson's Chief Population Health Officer, is joining you today. She will share much more of how we are working creatively in these spaces. Thank you to those attending today for their interest in this topic, and thank you, Wisconsin Health News, for facilitating this event. Tim, I turn it back to you and to the panel.
Great. Thank you so much, Dr. Rathgaber. And thanks again to Bellin Health and Gunderson Health System for all of your generous support. Obesity is undergoing a rapid cultural shift, shedding previous perceptions that it's mostly a lifestyle choice. Doctors and medical experts are helping lead the charge to reshape obesity as a disease, one that can lead to hypertension, cardiovascular disease, stroke, and more. It's especially salient here in Wisconsin, where more residents are affected by obesity than other states. A new class of effective drugs have sprouted up to treat obesity, with more in the pipeline. But as doctors rush to prescribe pills, some worry that environmental factors and other root causes of obesity may be overlooked. So we're hoping to tackle these questions and more. We have a lot to talk about, so I am going to dive right into the questions. And Abbey, let's start with you. Just how prevalent of an issue is obesity in Wisconsin? How do we compare to other states?
Yeah, that's a great question. So at the Wisconsin Collaborative for Healthcare Quality, we recently published some information in our toolkit on our website. We found that in 2019, which is the most recent data we have for this particular question, 32% of Wisconsin residents were living with obesity. It's a pretty high percentage comparatively.
Great. Dr. Pabich, can you talk a little bit about the health implications of obesity? I mean, why Why is this such an important issue?
Yeah, so obesity is associated with a lot of things that people hear about all the time: high cholesterol, high blood pressure, diabetes, and all those things that lead to heart disease, stroke, and things like that. It's also associated with a number of other medical problems. So there's several types of cancer that are more likely to happen to people who have obesity. There's mood disorders associated with obesity, and if you think about it, if you can't move easily, if it's hard to go enjoy spending time outdoors or with family and friends, it has a profound effect on mood. And really, other things are also big considerations. So we've moved from having hepatitis viruses be the biggest cause of liver transplant to now having fat infiltrating the liver be the biggest cause of liver transplant. So it's really affecting all of the areas of the body.
Andrea, or I'm sorry, Dr. Golden, well, what can you add to this? Well, why is this something that we need to take seriously?
Well, we've put so much more research in the last several decades into understanding obesity and its impact and its associations. And we now believe there are over 200 medical conditions that are either consequences of obesity or are worsened by obesity. And, you know, in primary care and in medicine in itself, we spend so much time and so much energy treating all of these conditions that really, if we focused on obesity, those conditions may not even be an issue for so many patients. So it really gives us an opportunity to truly treat at the root cause, which is what we always want to do in medicine. And often we're criticized for not treating the root cause. But this is one of those amazing opportunities in medicine that we are able to trace so many conditions back and treat the actual problem.
Andrea, in your work to address social determinants of health, how prevalent of an issue is obesity? What are some of the environmental factors that are at play here?
When we think about obesity, I like to also think about it through the lens of having a healthy weight. So our job really is to walk alongside everyone we serve and help them lead their best life or their healthiest life. Healthy weight has a significant impact, as the physicians just educated us on overall health and well-being. It's fascinating now because we have access to just a significant amount of data. And as you alluded to, Tim, we can collect information on the social determinants of health for all people that we serve. 80% of our health doesn't really have anything to do with being in front of a physician. So really understanding all of those factors that can influence a person's healthy weight, ranging from access to nutritious food, sleep, how much people move. And we can see, based on populations, defined populations, the prevalence of unhealthy weight. And we can also see what factors through the social determinants of health contribute to that.
Thank you. Jean, I want to switch to you. You have struggled with obesity personally, and I appreciate you telling us beforehand that this is something that you would be willing to share. Can you just talk a little bit about what it's like to be a patient with obesity?
Well, I would tell you that even though I am a clinician myself, I'm a pharmacist, and I'm knowledgeable about the disease state, obviously, because my company is heavily invested in trying to improve outcomes for patients. Even at myself, I don't know that I fully understood for years and fully internalized and accepted that obesity is a disease until I saw, for me, it's been now 13 years since I started losing weight, and it's still an everyday battle. It's a big challenge. And that probably is what it took before I got to the point that I fully understood that so much of this disease is outside my control. So our company is spending a lot of time trying to help people understand that, because it's powerful when a patient finally has an epiphany moment and gets that there are things that I can't control in this, and this is not a choice on my part. It's not my fault. So just the stigma and bias that comes along with obesity as a disease is such a hurdle. We've spent a lot of time also making sure to educate all the providers we work with on things like patient first language. You know, we should not say obese patients. We should say patients living with obesity. I think it was either Fatima Cody Stanford or else it was Dr. Fitch that I heard say, you know, when we're treating a patient as terminal cancer, stage 4 cancer, we don't call them morbidly cancerous. Why do we call patients living with obesity morbidly obese? So I would just say that that's one of my personal asks, is that we all be very thoughtful about what the impact of that is.
Well, thank you. And Jean, thanks for sharing that. I guess, can you talk just a little bit more about what are some of the ways that patients do experience obesity stigma or weight bias?
Absolutely. There are so many things that people are doing from an unconscious perspective that they maybe don't even realize they're doing. Things like, I see more of this now, not just patient first language than we used to, but we still hope it will get better. Clinics thinking about having chairs that are big enough for people that live with a large body size, having an exam table that will accommodate a person of a larger body size, access to open MRIs, even something as simple as being able to put on a gown that fits you before you have an exam. All of those things are critically important. And then helping patients get to the point that they understand it, and their families and caregivers, is also very important.
Dr. Pabich, what are some of the persistent myths around obesity that are hard to shake?
I would say one of the biggest ones is that it's within the control of the individual. The way I now perceive obesity is that you've got two different parts of your brain that are controlling what you might be eating on a given day. One is what I call the lizard brain, the primitive brain, the hypothalamus that is designed to keep us alive. And then the other part is the frontal lobe, the part that makes us human, that helps us think that we have choices in life. And the primitive brain is always saying, human, eat available calories, find food and eat it, because I want to store food, because there could be a point in time when there's nutritional scarcity, there's not enough food available. Our frontal lobe is the one that's saying, like, oh, I was told to not eat all, unhealthy food, and I have to make good choices and things like that. But it's very hard to overcome that primitive brain all the time. And some people have this upregulation of that. I've found that with some of the newer medications, when people have that primitive brain kind of suppressed a little bit, the medications that work on the hypothalamus, they say, I no longer am having this argument with myself about what to eat. I used to drive home every day, see the McDonald's, and think, like, you know what, it would be so easy to turn in and get some food. And I would argue with myself every day. 5 days out of 7, I wouldn't make that turn, but a couple times I would. And now I don't have that internal struggle anymore. That primitive lizard brain hypothalamus is no longer forcing me to want to seek out food all the time. And so it's made me understand that as much as we all have thought we have control over what we're eating, there's very much something deeper rooted that's making that where we don't actually have all of the control.
Thank you. Dr. Golden, kind of following up a little bit on what Jean was talking about. How does some of this weight bias, this stigma that does persist, impact how care is delivered?
It permeates, I think, every layer. I think first with the patient themselves, there's a lot of internalized weight bias and stigma. A lot of patients, I share openly with my patients, and when I advocate, I'm a obesity medicine clinician, but I also am a person living with obesity, and I share that a lot. And even being considered, an expert in the field in my area, there are times that I even will still say, oh, but should I be trying harder? I should try harder, right? And really buying into that attitude and that thought of it's just a willpower issue. It's that you're not trying hard enough. You haven't tried the right thing. And helping people understand that it's not about their willpower. They may have a hormonal imbalance that is constantly sending them messages about needing to eat. And if one person gets 100 messages a day about needing to eat, and one person gets 1,000, and they both, only say yes to 10 of them, well, I'm sorry, that person has a lot of willpower. So a lot of these medicines are just able to level that playing field a little and restore that. And a lot of patients still have trouble accepting that it's okay to ask for help, and that it's okay to take medicine if they do need medicine. and that these medications are helpful and not something they should be ashamed of using. So I think that's one of our biggest barriers, is that internalized weight bias. And then we have bias within, unfortunately, the healthcare community. Even though obesity was recognized as a chronic disease in 2013, I believe, by the American Medical Association, a lot of the medical community has not necessarily bought into that, and is still stuck in this. It's as simple as eat less, move more, calories in, calories out, which is a very oversimplified model. So some patients who have developed or the ability or the brave enough to go and ask their doctor about getting treatment, they may be met with, "I don't treat that," and then they're stuck again. And then if they're lucky enough to get a physician that will treat them, they may be met with barriers from their insurance company stating, "We don't cover obesity. This is a vanity issue. This isn't a disease." So there's just so many layers throughout the whole system that our population struggling with this condition is met with.
How, Dr. Pabich, I guess how widespread is that stigma that still exists amongst the provider community? I mean, so you and Dr. Golden you specialize in this. You've spent a lot of time researching and looking into this. Amongst your peers, how prevalent does this bias from a provider standpoint continue to be?
So I was in internal medicine residency in like 2014 through 2017. And I knew I was interested in treating obesity medicine. I looked all over Wisconsin to find someone to teach me how to use these medications. And they may have existed, but I did not find them. I ended up traveling to Colorado to learn how to use these medications because I just couldn't find anyone who was comfortable using them. Since then, since I've developed my own comfort, I do a lot of education to encourage my colleagues to start prescribing these medications because I know that we can help people. It's now at the point where I've had patients who were on multiple diabetes medications, multiple blood pressure medications, and we've replaced those with a single weight control medication. And I'm trying to help my colleagues see that. But there are some medicines that have been stigmatized. Phentermine was approved way back in the 1950s. It became something of like a doc in the box, like go and get your diet pills and use these and drop weight for a beach vacation or someone's wedding. And it was very much used in a way that was consistent with the vanity aspect. And I think because that history has come before this current really extreme medical need, there's still a stigma when somebody's talking about using that medication. So I'm like reaching out to all of my colleagues across the state. Please, if you are interested in using these medications, I really want you to start using them because I think we're really helping patients.
Dr. Golden, at what level do you think some of this care is being integrated into primary care, and what are maybe some of the barriers for that to happen?
I think there's a strong attempt to do that with some of the approaches that are being pushed forward in terms of the primary care provider being able to provide like intensive behavioral therapy to work on lifestyle changes, the reimbursement to help support providers to take that time is coming forward. But it continues to be a training issue. I mean, primary care physicians have to handle so much. And their time face-to-face with patients continues to become less and less and less. And treating obesity and working on weight health with a patient is not a 10-15 minute thing. And that's one of the biggest barriers, I think, for primary care. So there is more and more training becoming available to the ones coming through family medicine and internal medicine residencies, far more than what we received, because it is starting to change some. So I think we're starting to address that education barrier, But I think that time challenge will continue to be an issue for primary care physicians. And that's why one of our biggest campaigns is treat or refer. If as a primary care physician, if you want to learn to do this, if you want to treat a patient, please. And there's many of us, like Dr. Pabich said, are more than willing to help support and help encourage physicians to do so. But if you're not comfortable, at least offer the patient a referral to someone who is, because the statistics are terrible as far as the amount of patients with obesity that are being offered treatment. It's I hear over and over, like 2 to 5%, only 2 to 5% of people that are eligible for treatment are being offered it. And that's just really disappointing.
Abbey, in what ways does this bias impact the quality of care that's delivered?
Oh, that's a great question. So, I don't have a lot of data on this, but what we know is that there are myths that persist about obesity, that obesity is the root of all healthcare problems when you go to your physician. And so what this can lead to is other things being missed, or patients not receiving adequate treatment for conditions that they may have because their provider is asking them to try to lose some weight, and then we'll talk about your pain in your joints, or try to lose some weight and then we'll look at your blood sugar. And so what this can lead to is lower quality care when we look at quality outcomes overall.
Andrea, in what ways is this bias impacting what social determinants of health are looked at? Is it possible sometimes things are overlooked due to a bias around this?
Well, I think we're working really hard to acknowledge that, and then to focus our attention really in avoiding that and on the right thing. I love what Dr. Golden said, because she talked about the care team. And I think that obesity is something that it will take all of us to walk alongside with the people that we serve, and put our arms around not only individuals, but the care teams that care for these patients, to align resources to make sure that our physicians have extensions of themselves that they can work with to really provide that time and attention that this needs. And then partnering with the community to also engage them in everything that we've been talking about, and putting our arms around the people that we serve. And there's some really interesting examples of creativity that can be injected into this work. In the Gunderson region, as an example, there's some great work being done in partnership with the YMCA here and the Healthy Living Center, where there's a teaching kitchen for cooking classes. There's time and space to carve out coaching and counseling that perhaps the provider doesn't have in the exam room in that limited time that person has with their patient. In the Bellin region, as an example, partnering with communities. So data, we have so much data that it really allows us to just double, triple click into what each individual county or community needs. And based on that data, we can empower and partner with the community to promote opportunities to move bodies, or to eat better, have access to healthy foods. So there's a whole run series now in northern Wisconsin that was grassroots to help engage the community, community created to move and to run. And so I think that it's our job in healthcare to partner with the community, our patients, and our care teams to make sure that we can activate and really walk alongside with our patients and our community members on their journey with this.
Mm-hmm. Thank you. So it sounds like there still is a decent amount of bias and stigma that exists. But Dr. Pabich, correct me if I'm wrong, it does seem like it certainly less exists than did previously. There is more of an acceptance, an overall acceptance that obesity is a disease versus a lifestyle choice. There are now new treatments, increasingly effective treatments out there that is changing the way obesity is treated. Could you talk just a little bit about what is driving this shift into more of an acceptance of obesity as a disease?
Yeah, I'd say we still have a long way to go, because I still encounter lots of people who don't consider it, like at the forefront of their mind as a disease. But I think part of what drove it is a new class of medications that was introduced for the purpose of treating diabetes, the GLP-1 inhibitors. And they weren't something that we were using for the purpose of treating weight. But what we found is that when people were on these medications, they had this reduction in their appetite, and they had a compensatory weight loss. And then it became clear that, like, hey, there's something that if we are altering a little bit of brain chemistry, we no longer need to put so much emphasis on the you and you're making bad choices and things like that. I've found that one of the best predictors of whether my patients are going to have success with weight loss is if they are feeling hungry all the time, if they're feeling like things are off limits and that they're not able to have the foods that they want. That's actually telling me that there's something going on with their brain chemistry more than anything else. It's not that they're weak-willed. Their brain has upregulated their hunger hormones and has upregulated their desire for food. Similarly, we know that so many psychiatric medicines that act on the hypothalamus cause an increase in weight. And so really it's because we've had these medications that are used for other things that we've seen how they affect what happens with weight. And I think it's really driving that understanding that it's a biochemical process at the hypothalamus.
Jean, in terms of the stigma issue, do you think the progress has been made in terms of how this is perceived? And what role is Novo Nordisk playing in kind of increasing that awareness and providing that education?
Well, I think we have come a long way, but I completely agree with Dr. Pabich that there's still much we need to do to improve the situation. I mean, we've been committed to trying to talk about obesity, make people understand it as a disease, continually emphasizing the importance of, we've talked a lot about medication today, but there are multiple treatment modalities for patients with obesity, and people need access to all of it. Everything has to be built on the foundation of lifestyle changes. That isn't going to fix the problem, but if you don't address that for the rest of your life, you can't be successful. So people have to understand really what is a healthy diet. There's education needed there. Many people, that was my personal experience when I listened to the other people that were being treated in the clinic I went to. The people didn't even have the first idea what healthy really means. So my company spends a lot of time educating patients, educating physicians, and then working with a whole variety of constituents like this organization, like WCHQ, all the health systems in Wisconsin. We have a lot of educational resources that we can bring and offer to people that they can use at no charge. I think it was Dr. Golden made the point that primary care doctors' lives are very busy. We have some things that are simple resources that patients can be given that help to further that conversation, at least sort of address the time crunch that physicians are living under. I would say that so many things have happened recently to shine a light on the stigma and bias, and some of it, like social media, some of it is really good. There are now a lot of resources out there. There are patient advocacy groups that are giving people a place to lend their voice to this conversation and help people understand, patients, families, providers, what obesity is and then what it's not. But there's also a lot of negative misinformation out there that I worry about a lot, that I hope that people are able to discern what is reasonable information they should listen to and what is not. Stigma and bias is absolutely still alive in social media. And the last thing that I'll say is, one thing we work on a lot is trying to make people understand what treatment should be and shouldn't be. It isn't about losing 10 pounds so that you look good in pictures when your daughter gets married. This is medications in particular for people who need to lose a significant amount of weight and change their lives. So one wish I have is if we could keep celebrities off TikTok and Facebook and everything else. I think that probably would make our lives easier, but it might not be practical to think that will happen.
It might impact a whole range of issues besides just this one.
Absolutely.
Dr. Goldman, can you talk a little bit more about just how obesity treatment has changed? Dr. Pabich has talked about these new treatments that are available. But how does that fit in with, how does bariatric surgery fit in? How does lifestyle choices like nutrition and exercise fit into the overall treatment for obesity? And how has that changed in recent years?
I think it's changed in several ways. First of all, we're treating it. It used to not really even be treated. People could go to the doctor and say, hey, what about my weight? And that's not really a medical issue. That's a personal issue. Work on it. So I think one of the big differences is that we're just simply treating it where we weren't before. Otherwise, I mean, the comprehensive approach, I mean, I think there's a tendency for us to go right to medicine conversation because it's such a hot topic right now. But it's so important for everyone to understand that when we're treating weight successfully, we're treating it in a comprehensive approach. All of those medications were studied along with lifestyle intervention. So in no way is it surgery or medicine or maybe just lifestyle. It truly is all. I mean, we have to work on people's sleep, their stress management. We have to work on nutrition, their physical activity, all of it, their relationship with food. And then if someone needs medication or if they need surgery, that ties into the rest, but that's a foundation. So that comprehensive approach, I think, is what's different. And we pair that to the severity of the disease, just like any other disease state. We decide how involved the treatment is going to be based on how much is it affecting your life. You know, someone may not seem by appearance that they're significantly overweight to where a community member may think that they may or may not deserve medicine. But if they have heart failure already, and if they have liver disease that's threatening liver failure, then they need probably the most aggressive range of treatments that we can offer. Whereas if someone maybe appears to someone out on the street that they feel like they may need treatment, that person may at that time be metabolically healthy and may not need the entire spectrum. So we've done a really good job of making the treatment comprehensive and recommending it based on the severity of the condition and using all of the tools.
And Dr. Golden, how has how we treated obesity for kids changed? How have the guidelines treated for change for pediatrics?
So we've seen a lot of change in the last few months for the pediatric recommendations. We look at children a little differently when we assess their weight, just like when children are growing up, we use a lot of growth charts. Well, we use the growth charts to assess the weight, the risk for them as well. We used to not start working on lifestyle changes and nutrition and physical activity approaches until 6. That used to be the previous recommendation, that at 6 years, you would start to work with a family more intensively. And now the recommendation is 2, to start as early as 2. Which I think is wonderful because we're learning so much more about the longer this disease state is allowed to continue, the less chance we have of reversing it and improving those outcomes. So that doesn't mean that patients are offered medicine at 6, at 2 now. We start to actually evaluate and have frequent interventions with the family at 2 rather than waiting till 6. And we now have medication options available for adolescents, where many of our medications that have been very successful were only approved for adults. And in the last year, we've seen a lot of those approvals with recent clinical trials coming with results coming forward, being able to offer these medications to children as low as 12.
And Jean, could you talk just a little bit more about, as you kind of addressed it, just how, I don't know if we've focused enough. I mean, we focused a lot on the new medications that are available, but can you just talk a little more about just like how they've changed? I mean, the medications that patients can now get, are these different than what a patient could get 10 years ago, 20 years ago? How have they changed? And what's in the pipeline? It's my understanding that there's more coming.
Oh, I have lots of thoughts about that. I'll try to be articulate and organized in the way I approach it. Yes, things are very different in the last couple of years than what they have been historically. I actually was still a dispensing pharmacist when the fen-phen debacle occurred, so felt that very painfully firsthand. But it used to be that where medications were concerned, we could see from, let's start first with lifestyle changes. We typically see somewhere between 0% and 5% weight loss possible with lifestyle changes alone. And until the last few years, single digits were on top of that were associated with medication therapy, meaning somewhere in the neighborhood of 6 to 10% weight loss on average. You know, some patients would be more successful than that, but that's generally what we saw. Then with the advent of medications in the GLP-1 class approved for obesity, we're now seeing today 15 to 18% in the average population. And there are more medications coming, some soon and some further out, that are looking like we may even see higher percentages of weight loss. So even at 15 to 18%, that's approaching the level of what the least invasive bariatric surgeries have typically provided on average. And you know, what happens if we get to the point someday where we're able to deliver 25 or 30% weight loss? I think that's possible. I hope it's possible in the future, because there are a lot of different companies working in this space, and there's different treatment, there's different mechanisms of action being tested. So I think things are going to change a lot in the near future. At least I hope so. And the other thing that I will say is it is important to always think in terms of access to care for all the treatment modalities and moving back and forth between those interventions. What each person needs, is ready for, is willing to do, is different. And their pathway will change what they need over time, because it is a lifetime of disease. So I think there are a lot of things coming where I hope that we're going to learn how to better tailor treatment for each patient based on what their individual circumstances are for obesity.
Dr. Pabich, these treatments are, as Jean laid out, increasingly effective, but they're also not at all cheap. And as of now, it's not something that Medicare covers. A lot of insurers won't cover them. How do you as a provider balance recommending for a patient a medication, knowing that, you know, just how expensive it could be for them, potentially out of their pocket?
Yes, it's a great question. And I would say largely my patients in Wisconsin do not have coverage for these newest medications. It's almost all the time that my patients are not having coverage. And I've talked to insurance companies about this, and I've asked the question, like, what would it take for you to cover these medications that could be so transformative for your patient's health? And a lot of insurance companies are a little bit worried that if they were to start covering these medications, there would be a run on them, that, 75% of patients that they cover could theoretically be eligible for these medications, and that it would be enough to bring the insurance company under. The way I'm thinking about it for insurance companies is maybe that we risk stratify, that we start covering these medications for the people who have the comorbidities, like Dr. Golden was mentioning before, that we kind of wait out the patents on the drugs, because some of them are going to come off patent this year. I'm really excited. And that we use some of the medications that are available generically right now in the short term. In the long term, I think that these medicines are going to become very common once they come off patent. I hope that they will be more affordable, but for right now, it does remain a big barrier. And I struggle internally with, some of my patients say, I have enough money, I can pay $1,000 a month for this out of pocket, and I want to. And that's creating health disparity for the, because the patients who can afford that price tag are going to help their health, and the patients who can't afford it are going to continue to struggle. So yeah, I don't have the right answer.
And how as a provider does at this point, knowing the cost of these medications, how does that impact other treatment options? I mean, bariatric surgery, for example, is more covered by insurance companies. Is that just not as effective? Is it for certain patients, or is that, I mean, we're as kind of was mentioned, we're hearing about the treatments in the news a lot, but we've had bariatric surgery for a long time. It's more covered. Is that just how does that fit in to kind of your treatment plan?
I'm a medical practitioner. I don't do any cutting, but I actually highly recommend bariatric surgery for two reasons. It is the most efficacious and most durable strategy we have for weight management. And it's been newly recommended at lower body mass indices than it previously was. So it is now theoretically going to become more available to more people. People who have bariatric surgery typically lose about 30% of their body weight, and it comes for a lump sum price tag. I think a lot of bariatric surgery costs between $20,000 and $30,000. And at the point right now where we're talking about $1,000 or more per month for a medication, you might recoup that cost with a bariatric surgery after 2 years. And so it's something that for the upfront price, we know that we have good weight loss data where the weight loss is durable out to 10 years and probably much longer. So I think bariatric surgery is definitely an underutilized strategy. And there are people for whom bariatric surgery doesn't make sense. That's where we should be thinking about medications. But I think a lot of patients are worried that bariatric surgery is too invasive or too drastic, or they're not bad enough yet to merit surgery. And I certainly try to change that perception in my clinic, because it's a very safe, relatively non-invasive procedure that is very, very effective at preventing medical consequences of obesity.
Jean, can you just, I guess, respond to the cost issue? I mean, it costs money to research and create these drugs, but at the moment, as they aren't as covered and they can be really expensive. I mean, what does that mean for patients that need access to these drugs?
That's something that we spend a lot of time working on and thinking about. And I'm not going to lie and say that I know what the perfect answer is there, but I think we all recognize that that's a challenge. My company, in concert with a lot of other advocacy groups, like, for example, the Obesity Action Coalition, that's just one of many, are working to advocate, for example, at the federal level. One of the big barriers that we still have today is that Medicare is not widely covering medication therapy. And they didn't until, I don't remember the year, not too long ago, cover surgery. And when we talk to organizations like that, we really do emphasize that access to every option is critically important. So working at the federal level, we also work at the state level on things like making sure state employee organizations have access to all those treatment modalities. Similarly, that Medicaid is paying for all the treatment modalities. One thing I'll say that's a very positive thing for Wisconsin is that Medicaid patients do have access to medication therapy today, and there's only a small number of states across the country that are in that place. So that's a good thing. And we're working to support making the argument of why this is important. And it is very hard to tease apart cost offsets. In my previous life, before I came to this company, I spent a lot of time working on trying to prove an improvement in outcomes, which by definition you almost can't do. You can use mathematical models. So we do a lot of work on trying to quantify, if you get upstream from these 60 comorbidities or more that we've talked about, what do you do in terms of improving outcomes and avoiding costs? So we do a lot of work in that space as well. And I hope that someday we'll get to the point that one of my personal frustrations living as a patient with obesity, we don't say to a patient with type 2 diabetes or hypertension or osteoarthritis, yeah, I shouldn't have to pay for this medication for your disease, but we're still in that place for a lot of patients living with obesity. So I feel a little bit like Dr. Pabich, where I don't know what the perfect answer is, but it's going to require all of us working together to get there.
Dr. Golden, as these treatments, gain popularity, and more awareness of them, is there a concern that some of the other sides to this, the exercise, the nutrition, the things that can make not only an impact on obesity for some, but just on overall health for many, can get overlooked? If a patient just says, now I can just take a pill and solve my issue, why do I need to spend all this time working on these other things? Have you seen that, or is that a concern maybe at all going forward?
I think I hear that argument a lot, or that concern a lot. And just like anything else, these medicines, they're very good, but they're only going to take you so far unless you add the whole treatment into it, right? So you're still going to get the most benefit from adding the physical activity. You're still going to get the most benefit from improving your nutrition. And we see that in the clinical trial results. I see that all the time in my patients that I work with. And the longer patients are on it, as they see more results and more benefit, and they get more and more control of those urges and cravings and all of that brain chatter, that even the patients I have that are a little resistant to make a lot of change potentially at first, as things move forward, it's easier for them to apply these recommendations. They want to, they just have so much more ability than they ever did before to apply it at the beginning. But but I struggle with a little too, this idea of requiring, because some insurance companies and some doctors will say, you have to prove to me for 3 to 6 months that you've made all the lifestyle changes before you can have this medicine. And I ask, do we do that with diabetes or high blood pressure or heart disease? If someone comes to me and they've had a heart attack and I need to treat them to prevent another heart attack, and they smoke and they don't want to stop eating high risk foods, I don't say to them, well, you don't get any medicine until you quit smoking for 6 months. That's the rules. We don't apply that to anything else. So it's just another layer of that stigma, that bias. Does exercise help with obesity? To be honest, it doesn't really help that much. I mean, the research shows it really doesn't help that much. It's pretty good for weight maintenance. It's important for so many other things in our health. But people are not, if someone needs to lose 10, 15, 20, 25% of their weight to stabilize their diabetes, exercise alone is not something we can count on making that happen. So it's a part of it, but we should not be making patients prove to us that they have earned these medicines, especially someone who's lived a lifetime trying to find the answers. And then we ask them, well, have you tried to lose weight without medicine? It's very offensive. So I don't want to take too much time, but I do want to circle back, because I am very thankful in the state of Wisconsin that we do have Medicaid coverage. But unfortunately, it's just another misunderstanding and stigma and bias again, and doesn't go along with the disease state. This is a long-term, lifelong disease. In Wisconsin, Medicaid approves the medication for a year, and then a patient has to come off of it for 6 months to see if they can maintain their weight on their own. And then they get it for another year, and then that's it for their lifetime benefit. So everything that we know about this disease, essentially we've given them a medicine to help them with making changes, potentially worsened their hormonal imbalance when we take these medicines away. And we put them at a disadvantage when we're taking them off the medicines. So our approval within the state of Wisconsin for these medications is not backed by science in any way, and is just another example of the misunderstanding of how this disease works.
So how, just a quick follow-up, Dr. Golden, I do want to shift a question to Abbey, but how do you as a provider then balance that cost part of this? I mean, as Dr. Pabich brought up, I mean, I think among the arguments an insurance company would make is that, these are really expensive. And if all the eligible patients that could qualify for medication got medication, I mean, that would empty our account. I mean, just the expense that would cost. I mean, so how do you balance that as a provider and what you recommend?
I'm always very transparent with my patients about what is available out there, whether it is available for their insurance or not. I don't like to play the game of I'm only going to tell you what you have access to. I educate them and let them understand what the barriers are, because I don't like to pretend that I can make the choice for them at all. But it is a significant problem. And the best we can do is continue to advocate. We try to talk with the local politicians to try to get them to support the Treat and Reduce Obesity Act, which would require Medicare to cover these medications. But And I understand that it could be expensive, but not all patients want these medicines either. A lot of times when they do the cost calculations, they assume that everyone will want them. And I'm sure the other clinicians can vouch for this too. I see patients all the time that they don't want medicine. So we can't assume that everyone will want them. But at the same time, I don't think we can afford to continue to just admire the problem of obesity either. It's not going to go away, and it's just going to get more expensive potentially if we continue to allow people to progress with this disease and develop this disease and not do anything about it, even though we have the treatment options that are successful now.
Thank you. Abbey, the collaborative, as you have mentioned a little, has taken a focus on this issue. You formed an advisory committee to look at it and to help guide providers as they treat this. Among the things that you have done is provided launched a toolkit. Could you just talk about that and some of the other areas that you're focused on as you move forward with this group?
Sure, I'd be happy to. So we've been very lucky to work with a number of the folks on the panel today on our obesity advisory group and our obesity toolkit. Our advisory group takes a multi-stakeholder approach to addressing obesity and the care quality that goes along with it. So that group is made up of physicians, quality staff. We have our corporate partners from Novo Nordisk involved. We work with payers, epidemiologists. It's a large list, population health. And we launched that back in 2021. And then this spring, we launched our toolkit. And so the advisory group really focuses on the patient progression after diagnosis of obesity. We talk a lot about stigma, a lot of the things we've talked about here today. We provide education and best practices to clinicians. And try to spread some of the messages that we've heard today from the physicians on the panel. And we've also tried to open that dialogue between providers and payers and talk about coverage, we're starting to focus on employers and benefit design and how do we get these really efficacious treatments covered. The toolkit that we published, which is available on our website and is free for anyone who wants to work on this, has a number of resources and sections. We have resources on how to have these difficult conversations with patients, talk a lot about patient first language, people first language, how to talk to your patients, how to have these conversations. We do have a whole section on common obesity myths, a lot of the things we've talked about today. Care planning for patients. The importance of lifestyle factors is also something we talk about. And as the providers have, or the clinicians have mentioned, these are things you should do because they're good for you, not necessarily because they're going to help you lose weight, but you should get exercise and you should, eat healthy foods because it's good for you for a number of reasons. And then lastly, we talk about clinical operations. So how do you bill and code and some of the nitty gritty details of if you are trying to submit a claim for this, how do you do that? And our goal is to provide, and we have sections for, we take both a provider and a patient perspective here, and we're trying to get kind of everybody involved in addressing obesity as a disease state.
Excellent. So we are quickly running out of time, but I want to sum things up with a final question for each of you. And Andrea, we'll start with you. But overall, how do you see obesity treatment changing and evolving in the years to come? Andrea, from a population health standpoint, how do you see things evolving over the coming years?
Thank you for that. I actually feel like we have to focus on prevention to the extent that we can. And, there are populations that have a disproportionate percent of obesity. Our rural underserved areas, there's certain ethnicities. We know that there's populations who have more barriers than others. So going upstream as much as we can and eliminating barriers, and not just from a community perspective, but all. So Tim, we need to remove your barriers. We need to remove Abby's barriers. We need to, so unique one person at a time and at the community level and at the systemic level. So I think that obesity absolutely, as the physicians have beautifully described to us today, definitely we have to treat. But I also think we need to equally focus on prevention. And like the combination, the and strategy that was referred to earlier by Jean, we need to focus on lifestyle medicine, like at Bellin with our lifestyle medicine team. We have to focus on the prescribing. But I would love it if we could avoid all the costs that we talked about earlier by actually preventing where we can the condition from even occurring. So I think that we're going to see a lot more work in the space of upstreamism. We're going to see a lot more work in the space of activating communities, starting to focus with kids. Representative Shelton right now is sponsoring, looking at trying to get approval in the budget for free school meals for all kids. How do we put healthy food into all of our children and start them off right? So I think the focus is going to be community, upstream, and prevention.
Great. Thank you so much, Andrea. Jean, how do you see things changing and evolving in the years to come?
Well, I hope that in 10 years, we're going to look back and say, wow, look at how many more tools we have in the toolkit today than we did 10 years ago. Things that I already mentioned, like different mechanisms of action. But my hope is just that we have to finally shed our belief that what we've been doing is helping, because it's not. We all have to work together to figure out how to fix this, because obesity is rampant and it's growing quickly. I'll just say that the two things that probably keep me up at night the most are that the two groups that are growing the most rapidly are those patients with severe obesity, so class 3. And those are people for whom that's an emergency potentially situation. They have terrible health outcomes looming in the very near time horizon. And the more that number grows, the more it scares me. Kids are the other group that are growing really fast. So I worry about this tsunami of bad health outcomes that I feel like is coming quietly, and we're just not really paying enough attention. The good news in all of that, no matter what treatment modality we're talking about, is you can start to see improvements with as low as a 2% body weight reduction. Up to about 15, we start to see very significant changes in a person's outlook and what their future looks like. So my hope is that we'll have a whole lot more tools. I think we will, and that we'll have learned how to apply them in a personalized way. Our CMO says obesity is obesities, because every person's different. The more we can figure out how to tackle that on a single patient basis, the more successful we'll be.
Thank you. Dr. Pabich, how would you answer that question? What's next for obesity treatment? How will this evolve in the coming years?
Yeah, it's a great question. So I'm going to consider myself both an optimist and a pessimist at the same time, because as others have said, like, really what we need to be focusing on is prevention, but humans and capitalism make prevention something that just like hasn't happened yet. Like, anytime that somebody can make money by selling you high calorie, long shelf life food, we're going to live in an obesogenic environment. And so what I'm hoping, what I think could happen is that anti-obesity medications will become more available to people who are already struggling with obesity. As that happens, I'm hoping that the production of unhealthy food and the prevalence of unhealthy food will decrease, because people will be on medications that cause them to desire it less. And hopefully with that, the newer generation of people will not be as exposed to an obesogenic environment as we currently live in. I am an adult doctor. I treat adults, but I see the kids in my children's school, and many of those kids have normal weights, but they have terrible health behaviors. Cupcakes and juice and food are just available all the time. And we see that a lot of kids don't have problems maintaining weight until puberty or older. And we just need to change our culture. And I don't see that happening until we change something, I guess, at above. So make it so that juice is not normal. Make juice abnormal is what I'm saying right now.
Thank you. Thank you. Abby, how would you answer this question?
One thing that I hope happens, in addition to everything that we've heard so far, is that we start to see that there is a community benefit to treating and managing obesity, and which would then result in more coverage of treatment, more access to treatment for all patients, kind of regardless of what their financial situation is. As we're saying, the current costs create these disparities in who can access care. And when we can see that there is a community benefit, even from an economic perspective, a healthier workforce, there's a benefit to you as an employer for paying for obesity treatment, things like that. So that's my hope, is that we will see this as something that we as a community, as a world, need to address, and that will allow us to better treat patients broadly.
Thank you. Dr. Golden, we will give you the last word. What's the future of obesity treatment?
I would like to think that we will be in a situation where it is accepted as a disease, and the community and patients are comfortable bringing it up to their providers without shame, and that it's appropriately diagnosed, and they're offered treatment if in any form that they want and would work for them. And then I think we will really start to see, especially if we can start to individualize that treatment. I know it was mentioned with the obesities, right? So we're starting to see these individual types, and I hope we can start to personalize treatment more and more. And then we'll start to see this generational impact, right? As we all get healthier, we'll have less behaviors, and hopefully these genes won't be expressed in generations to come, and we can start to see our community change.
Excellent. Well, thank you all so much. This has been really great. We really appreciate your time. Thanks to our generous sponsors for making it possible, and thanks to all of you for tuning in today.